there are certain scores. I want to emphasize that you use them. The H2F-PEFF score, which includes atrial fibrillation, the body mass index, if the patient needs antihypertensive treatment, if the patient has pulmonary hypertension, elevated filling pressures, and if the patient is above 60 years old, we can calculate, and depending on how many points we actually have, the probability for HFpEF is more likely, or if there are 0 points, we can most likely exclude HFpEF, so heart failure with preserved ejection fraction. The second score I personally like to use, because it includes a lot of echocardiographic measurements, is the HFA-PEFF score. We have functional, as discussed before here. It is displayed even in more or greater detail what you can actually measure and what the cutoffs are. The septal E prime below 7 centimeters per second, the lateral E prime below 10 centimeters per second, or the average E to E prime above or 15, or the TR velocity above 2.8 meters per second, with a systolic arterial pulmonary pressure above 35 millimeters of mercury. The morphological criteria, the left atrial volumetric index above 34 milliliters per square meter, or also the RVT and the left ventricular mass index, are included in this as well. The biomarkers are included for sinus rhythm and atrial fibrillation as well. You can see the major criteria and the minor criteria, and you calculate points, and if you have 5 or more points, you have the diagnosis of heart failure with preserved ejection fraction in a symptomatic patient. So of course, we need a symptomatic patient. If we have 2 to 4 points, diastolic stress test or invasive hemodynamic measurement is recommended. So this has several steps, and depending on the steps and what the overall outcome is of the points, we can state that the patient most likely has heart failure with preserved ejection fraction, or if we need to do further testing, which was also mentioned in the guidelines. So diastolic dysfunction, HFpEF, we heard it already. There are plenty risk factors, we discussed them, and heart failure with preserved ejection fraction is definitely not a benign disease. It leads to hospitalizations. The mortality, the 1-year mortality and the 5-year mortality of 29 or respectively 65% is fairly high. The diuretic therapy is only for the symptom control, and the prognosis is, as we can see, bad. But we have treatment. We have SGLT2 inhibitors. They act in the proximal tubulus of the kidney. They are a sodium glucose co-transporter, and they or the blocking of the SGLT2 inhibitors induce glucosuria, so tinkling sugar. And what do? They reduce blood glucose. They also have a lowering effect on the blood pressure. They work independent of insulin, and you rarely have hypoglycemias because still you have SGLT1, which also resorbs glucose. And what is most important for us is that they are nephroprotective and also cardioprotective. And they are the first treatment for heart failure with preserved ejection fraction, where we know we actually can help our patients. They can be used for heart failure with mildly reduced ejection fraction as well. We have here the ARNI, the SGLT2 inhibitor, the MRA, and the beta blocker. And for the HFpEF, we can use the SGLT2 inhibitor. The AHA, the American Heart Association, stated that the SGLT2 inhibitors are a treatment, a useful treatment for patients with HFpEF. It's a 2A recommendation. The ARNI, or angiotensin receptor blocker, they show an effect with low normal ejection fraction, a patient with a HFpEF with low normal ejection fraction, same as MRA, so they are 2B indication. Loop diuretics, they are a class 1 indication for symptomatic patients. It doesn't matter if it's HFpEF, HFmrEF, or HFrEF. And SGLT2 inhibitors, of course, sugar, yes or no. So diabetes, yes or no. For the heart, it actually does not matter. We can use it for all disease entities of heart failure with reduced ejection fraction, mildly reduced ejection fraction, and even for heart failure with preserved ejection fraction. So keep in mind, tinkling sugar can be cool. This already summarizes this lecture about the phenotypes, and I also got in depth of the treatment and some more findings also of LVH. But overall, we have to have a knowledge of the clinical findings and the consequences the echocardiographic findings might have, and we have to measure accurately. We should use the clinical findings in combination with echocardiography to bring patients to a proper treatment. We should think about specific etiologies, especially amyloid heart disease. It's not that rare, we know that now because we know also the features in echocardiography better and better. So it's definitely a diagnosis to think about. Especially in the beginning stages, it's very hard, but with strain imaging, there's an additional tool which can help to identify also not so clear cases and bring to further testing. Echocardiography is a first-line tool, of course, for heart failure with preserved ejection fraction, also for LVH and all problems of the heart, basically. And initiate, and that's very, very important, initiate the adequate therapy because of your findings and the consequence you have when you, for example, calculate specific scores and reach the conclusion as a patient actually has HFpEF, a heart failure with preserved ejection fraction.